So it's a privilege for me to be here today, and Dr. Begovic and I have worked together on some of the things you're going to hear about today in close collaboration and friendship. So it's really a privilege for me to be able to share some of that with you. And it will also we'll also mention some of the things that you just heard from Dr. Gaich about how to study some of these effects. So I'm going to be talking about how we deliver critical care in a resource-limited and a cross-cultural setting, and go over a couple of objectives. One of them, I'm going to focus on telemedicine, and in the ICU setting, we call that tele-ICU, and just talk about what we've done over the last couple of years in particular, but bringing that up to speed with current day. Bringing that in a context that is, we live, not just in the US, but across the world in places with different access to resources. And there are cultural, language, geographic barriers, and differences that we have to associate with the medicine we want to provide for everyone. And we'll talk about today how we use tele-ICU in some of these contexts. What that means is trying to really focus on what's achievable, knowing that we cannot do everything, but we want to identify what's the highest yield aspects of the healthcare delivery in these settings. We want to study that impact because if we want any sustainable change based on the lessons we learn, we have to be able to demonstrate that. And really trying to convert that into new practice norms, and not just within the profession of physicians and nurses and other healthcare professionals, but in the broader community and with regard to politics and policies and all those kinds of things that will really move things on a larger level into making sure the healthcare delivery is where we want it to be. So just to begin, none of what I'm talking today has any disclosures I need to speak about. And let me begin by talking about what are the challenges that we see. And I will say that what you're going to hear is nothing new. I mean, these are things that have been in the minds of everyone in basically the last couple of decades, but certainly more recently, we need to have more critical care expertise in a community setting. We cannot just expect to go to large hospital, urban context setting with academic teaching hospitals all the time. We have a real need to bring that into community settings. At the same time, we want to make this as personalized and individualized as possible. We don't want a one-size-fits-all kind of experience. As we all know, and ChatGPT-4 and OpenAI and all these other types of analytical systems are bringing data and technology really front and center. And so how does that affect critical care delivery? We want to make sure that that's part of this. And finally, as we talk about the differences between what happens in large academic centers, which are usually in higher population density areas, we want to sync that and link that to what's happening with the community and provide access to some of the specialty services that can only exist in some of these academic centers because of cost, because of resource, because of specialty expertise. And those are really kind of the core components of critical care, not just in this year, but just in recent years. So how do we do that with telemedicine is a particular area of focus that I like to think about and implement. One of them is we want to keep patients, this telemedicine can allow us to keep patients nearer to home. They don't have to go to the big academic centers, again, usually located in big cities. We don't have to do that anymore. And at the same time, we can provide access to empowerment strategies and even bring some satisfaction back to the experience of healthcare at the bedside, whether it's a staff member, physician, nurse, patient, and family. We can do that with telemedicine. We're going to use data and some of these advanced technologies to drive quality outcomes. And finally, we're going to really use the resources more effectively in terms of strategic triaging, moving patients who need to have those specialty expertise and highly expensive and technical equipment, let's say, in the academic centers, while keeping folks who don't need those out of those centers so that we can make the whole system work properly. And so those are kind of the core concepts that we've used at UC San Diego in Southern California, but I think you'll probably find that these resonate in Bosnia-Herzegovina as well. And I'd ask you to think about how that might apply. So overall, the targeted role of telemedicine in any setting, but particularly the ICU setting, is we want to provide the access across geographic divides. We want to use that resource to utilize and triage the available equipment and expertise appropriately. And by doing that, we're going to be driving higher value. And as an example of what we're doing in Southern California, Dr. Begovic and I have worked very closely to bring what's happening at the academic center located in San Diego, a big urban center, out to more communities and community hospitals in more of a regional ICU clinical context. And I would ask you to think about how that might apply in your part of the world. So there are certain centers that may have higher population densities, but there are other centers that you may want to think about how to strategize some sort of regional and broader context of implementation and research and clinical healthcare delivery. So let me shift gears a little bit and talk about some of the technical aspects of what tele-ICU platforms really look like today. We kind of break them up into two different categories. One would be called decentralized, and one would be called centralized. And I've done a little bit of research in this area to point out the differences, both the side-by-side as well as a systematic review in the past. Briefly, decentralized systems are your peer-to-peer, point-to-point connections. We all know that anytime we do either a FaceTime or some other type of video chat on your phone or through an iPad, or through what we see here, we have some demonstrations of either robots with screens or other types of cart-based options. Those are providing a face-to-face audio-visual two-way connection that we can use. And I would call this sort of a virtual consultant. It's like you're in the room, except you're actually physically or remotely located. What it affords is flexibility. It affords a lean cost because these systems, as you can imagine, don't really technically, they're not that costly. But you do sacrifice some other things in terms of the analytics that some of the other systems provide. But they're easy and they're kind of plug and play kind of devices and platforms. On the other hand, there's a centralized monitoring platform, which is a little more sophisticated in design. You can see in the left part of the screen, you have really an architecture that involves a centralized hub where you've got everyone from medical assistants and clerical staff to intensive care physicians and nurses who are receiving direct data and information from a patient health perspective via video, via other types of data connections, electronic medical records, from direct connections. These are not usually through wireless connections, although they could be. And so they receive those into the centralized hub from the spoke centers. They're usually multiple hospitals. They then they assimilate, aggregate, and analyze them, and then deliver care back to those places by interfacing with other consultants. On the right side of the screen, you can see what that looks like in the hub center with that picture on the top. And the bottom, you can have an idea of what those analytics can offer. And I know Dr. Geich is quite familiar with this at the Mayo Clinic, where you can actually create pretty sophisticated dashboards for patient acuity and provide strategic interventions therein. But I will focus, regardless of the system that you use, I would argue that the best systems involve both humans and technology. And so we want to synergize what's happening at the bedside, but not forget about the human interaction while we use these thoughtfully deployed technological strategies. And what we've seen is that telemedicine and telepresence really should complement the in-person critical care service. And Dr. Begovic and I, on a daily basis, are involved in our program that does that. We have in-person intensivists, but we also have telemedicine services with many of the same staff. It's really trying to solidify not just the technology human connection, but also the connection between different academic centers of different sizes and different expertise, and really just different cultural worlds to bring those together. And so regardless of whether you use a decentralized or a centralized model, I would argue that that's probably the most effective, is to bring it into a hybrid context. Now, let's move towards what we would call a resource limited setting. And I would argue that limitation is really subjective because every clinical context, everything we do in life is limited. Okay, we're not infinitely wise, and we're not infinitely capable. We have physical and mental limitations. So what we want to consider in our strategy of healthcare delivery is moving from what would be considered ideal or perfect, and instead thinking about what is best possible given where we are, whether we're at the academic center or if in a rural community hospital. And in general, the following, I would argue, are what we would consider limitations, okay, when these are slow, unreliable, intermittent, or unavailable. Either personnel with the right expertise, technology, equipment, supplies, language can be an issue. I know that's no surprise to any of you. Data privacy and security, how we use the, how we are trained to use the technology. And a lot of these are based on pretty drivers of really any types of equipment or strategies, regardless of industry. So their costs, there's education, where people are located, where equipment is located, environmental concerns, and linguistic. And so let me just talk a little bit about what we found in terms of differences in Southern California. We have variations in our part of the world that, yes, we are within hundreds of miles of each other, but we've seen that there are variations across clinics and hospitals that are based on access to specialists. And so one of the hospitals we have has constant gaps in staff. We have nurse availability issues. Sometimes, especially during the pandemic, we had a lot of nurses that needed to move from one site to another. Some of them were actually handling adult patients when they were not specifically or strictly trained in adult ICU. There may be differential access to modalities such as ECMO, equipment. Even some hospitals don't have MRI equipment that can handle ventilated patients. That we see that in some situations. Certain technologies, in fact, even electronic medical records can vary quite widely. We've got hundreds of electronic medical record systems in the US, and this can vary, and how they're also set up individually can vary quite widely. Access to research-related experimental modalities, clinical research protocols, even the number of beds in a hospital can vary. All the cost of care, personalization of the screen. You can see that there are a number of things that we, Dr. Begovic and I, see in our own clinical work that can lead to a lot of different variations in practice. I'm going to give a brief example of how we see that this is actually a really example from the pandemic with a 49-year-old who had dyspnea. We found that in the emergency department, he had COVID positive testing. Oxygen saturation is quite low. He also was in clinical shock with renal failure. And this occurred in a rural community hospital right along the US-Mexico border, which was used to seeing probably on the order of 8 to 10 patients in their ICU at any given time. But this went up to as high as 28 to more, actually, ICU requirements. And this was quite far from the nearest academic medical center, which itself was overwhelmed in the pandemic. Plus, we had different staffing models in this hospital without any strictly trained intensivists until our service started. So you can see that there are a number of challenges that this patient was facing. Now, with our telemedicine service, we implemented this quite quickly. We started to walk before we ran. So we started with only a couple hours per day. Not ideal, but again, we're looking at best possible at the time. We had intensivists from across the training spectrum, from pulmonary to anesthesia to ED critical care providers. We used a decentralized model with separate electronic medical record and imaging access. And we were able to provide the following. We had supervised examinations with the patients with the assistance of the either respiratory therapist or nurse or both. We were able to directly visualize waveforms on the ventilator, something that they hadn't ever done before, and actually was very instructive to us as well. We made direct adjustments. We made all kinds of orders with medications, labs, imaging. We did this all remotely, created comprehensive care plans. And more than anything, and I'm going to talk about this in a little bit, we had collegial communication. We built trust with all the providers on site and remotely. And then we even factored in some education, because we do think that, our new generation of doctors, nurses, et cetera, really need to be more adept at this technology-oriented world. And so in our case, our patient received the following interventions. We were able to directly change the ventilator settings. You heard some of that from Dr. Malhotra this morning. We were able to do lung protective ventilation strategies. We were able to do recruitability assessments, driving pressure assessments, such as and such and such. We titrated sedation. We actually had to paralyze many patients with medications. We adjusted flow rates to look at desynchrony strategies. We did prone positioning. You also heard that from him. And we did it safely. Everybody had known about this before. It wasn't a lack of knowledge, but we were able to actually implement and execute that in an effective way. We focused on nutrition strategies. We looked at prophylaxis strategies. We facilitated renal replacement. We communicated everything with the hospitalists who were on site, and therefore had a cohesive closed loop communication strategy. And we even provided extra access. We talked about, providing the sickest of the sick to be able to get to receive some of these highly advanced specialty expertise and equipment with ECMO. So we facilitated that with our academic center site. And again, more than anything, we explained what we were doing. We coached staff. We provided reassurance. That was still, now that we're technically beyond the pandemic, that has paid dividends in how we deliver critical care even today. And Dr. Begovic and I see those benefits daily. So going back to what Dr. Gajic was talking, we had to study the impact. Why? Because anecdotal evidence, as much as it's meaningful maybe in the moment, is really just not enough. We need to have evidence. We need to have proof. We need to have other people recognize and learn from the lessons that we've made. And so I cannot stress that enough. And so having an analytical mindset really opens us up to thinking about failure, technically speaking, in a different way. We want to think like entrepreneurs who, if you're doing a startup, you basically are indoctrinated by thinking about failing fast and frequently. It's not the enemy. Not getting the perfect answer in the first shot is not the enemy. It's trying to find sustainable solutions by looking deeper. And so where do we focus efforts? Well, we need to look at, and this is what we did, rigorous needs assessment. We just don't want to look at what we think is important or might be important. We want to look at what's actually going to be important or is important today and create some key metrics around that. We want to think about our own biases. We have, as human beings, we have shortcuts, we have heuristics, we have cognitive biases that impact what we do and how we do it. And so we want to collect this data in a non-biased way. We want to analyze this. Dr. Gajic went into very nice detail about this. And we also want to think about presenting positive as well as negative results. Publication bias is real. And so we don't want to fall into that trap of just presenting things that look good to others. And so what we did in our program during the pandemic is we collected what we could, and in our strategy, we actually did a number of different structured interviews. And you can see on the left side that again, the perception of care was improved based on evidence-based strategies. You can see that before the tele-ICU initiation, it was at a certain level, and after that, it significantly improved. On the other side, on the right side of the screen, you can see that staff confidence improved for all ICU patients. This was sort of an interesting sort of bystander effect. We only actually focused on COVID patients because of the volume of patients. But you can see that even for non-COVID patients, the confidence of the staff to take care of them also increased. So this is sort of like a network effect of, basically change begets change, and positive reinforcement does exist. In terms of education, we asked what was the highest value of the service itself. Most said that, mechanical ventilation and adjusting those strategically and directly were really the highest yield intervention. And then the other one was just talking to a critical care specialist, someone to provide that level of expertise even if it's just reinforcing what someone is already doing. And just in terms of, what were the interventions that we actually made, you can see that, these data just indicate that since the beginning in April 2020 through July even, just a couple months later, there were much, much higher interventions that were allowed and actually allowed to be executed, and particularly in regard to ventilator management, but really across the board from prone positioning to even stress ulcer prophylaxis. We published this in Annals of Public Health. So what we found are the take-home messages of our Tele-ICU, really number one, front and center, was we generated trust. We generated trust between providers who are not typically working together, whether it be barriers of geography, linguistic, cultural, or even just views of evidence-based medicine. But we all focused on the same goal, the optimal patient care experience. And we did that by really just focusing down on bare essentials of clear, concrete, achievable care goals. We created awareness about what that means. How do we become realistic when there's really chaos around? And ICUs are, somewhat chaotic environments. But even drilling down into that further by really talking about what we can achieve today. And I will say that the academic centers, these physicians, really had a previous feeling of sort of disempowerment. They didn't feel like they could make a difference outside of the academic centers where they could have access to things that were very comfortable. But as part of our program, we were able to create a sense of connectedness with the remote providers. And on the remote side, this is in the rural community, they felt like inferiority in some ways, not being able to measure up to what's happening in the fancy academic research institutions. But we provided reassurance around that because most of the time the care was pretty close to where it needed to be. They needed to just have a little bit of support to move that forward. In addition, we had educational opportunities for trainees where we provided really context-specific delivery goals. Again, drilling down on the most essential aspects of the care, and that primarily included efficiency. So it's not just about knowing what the actual concepts are from the evidence, but actually actualizing that, executing that in a way that's effective. And so we moved to care plans that were made really on the spot with respiratory therapists and nurses in seconds to minutes. We didn't have to deliberate over hours to do that. And it was, sometimes it was those quick but solid, concrete interventions that made the most difference. And particularly with the communication. Again, you hear me reinforcing that relationship building over and over again, but it is really the foundation of really any types of change, and collaboration is essentially positioned on top of this foundation of communication. So whether it's empathy or just being strategic, just being very concise about how we're talking, professionally, respectful, and collegially, these are really just, I can't emphasize it enough how much of an importance it makes even today for making some of these healthcare interventions. And then we focused attention on specific areas that were really kind of interesting. And I'm just going to show you a couple of different screenshots of what we found. So these are when I was remotely interacting with respiratory, that's a respiratory therapist at the bedside. And so we picked up things from flow asynchrony to ineffective efforts to another flow asynchrony here, and then delayed cycling. We were able to pick up things and spend time with ventilators that were much different from what was before, and in some ways was even better than what happens routinely in academic centers where we spend very little time at the bedside these days. Okay, now converting this, what we found, into an actual practice, we do need to have that research, but we have to think about how do we do this on a policy level. And so really starting off any of this, and I would ask you to think about this, even when you have the evidence in hand, the data supports what you're doing. You need to involve a larger context of folks. These are stakeholders that really have to be asked to be officially collaborating. Where we were in the US-Mexico border area, we had to connect with local congressmen and the border commission on the US side, but also on the Mexico side in the northern Baja region. And so you can probably, this probably resonates with all of you in the Bosnia-Herzegovina area, where you've got different countries with different ways of policies and politics and everything else. So inviting them formally is important. We needed executive sponsorship from the institutions themselves. You know, things don't work out well if the leaders involved are not working together on an executive level. We needed to drill down with that needs assessment. That is a continual process. This is not a do it and we're done. It's continually, it's iterative, as Dr. Gaich said. It keeps going. We're getting things better and better and focusing on deeper and deeper sustainable solutions. Creating contracts and agreements to formally cement the relationship is crucial. Physicians needed to have protections. So when we actually had some tele-ICU services in Mexico itself as part of our service, and we had to make sure that those protections were in place. And in that situation, we only provided consultative support to local physicians who would then carry out orders. So that's very important. And then finally, you know, having the larger perception from the public, from the political leaders is important. And media, you have to think about how the media is going to present that. Sometimes it's not always what we intend it to be. So all of these different aspects are important in terms of making sustainable change moving forward based on clinical and research findings. And then finally, you need to have someone to drive this. You know, Dr. Begovic and I, almost on a daily basis, are the go-to point people for the program success. We need to have people who are going to drive that success every day. Again, it's not something that you set up and you walk away and it'll operate by itself. It's something that needs continual nurturing and nourishment. And so these program champions are essential. So in summary, I know our time has been short, but I want to just highlight that technology can offer ways to augment not just critical care, but we focus on that today, to really bridge geographic, cultural, and other barriers. Tele-ICU in particular, we've seen has been very effective during the pandemic, but even pre and post. We want to think about how this can be applied to resource-limited cross-cultural settings to, you know, make sure that these are not just clinically effective, but also cost-effective. And this is really predicated on strong trust building, relationship building with clinicians, medical professionals, and even executives on both sides of that of the relationship, on the academic side and the remote side. The awareness of how do we create realistic expectations about the best possible, moving away from ideal or perfect scenarios, and then providing opportunities for the new generation of trainees to learn about what we're doing and how we do that, not just for yesterday and today, but for really for tomorrow. So with that, and then I will say the last thing that was just highlighted is bringing the policymakers back into the equation and during this process of iteration to make sure that there's sustainable change. So with